One thing to build onto that too, in this world of CLL, right? There's a lot of innovation that's occurred in the last couple of years. Products there, more indications with certain products. There's also this doublet effect that we see in our clinics, right? Where you have an IV with an oral, and that coordination of care that's critical. You know, specifically, a good example is in CLL. So if you have that. What was the term you used? The
disintegrated.
Disintegrated.
I mean, it's not, you're selling me, and I'm buying on a medically integrated dispensing service. This feels to me like a disintegrated service.
Sure.
Because you're breaking the continuity, it seems, right?
Yeah, exactly. So Christina's example is a great example, and then you know there's multiple examples with different disease states where it can fall apart, as opposed to coming together when that continuity is not allowed to occur because of payer constraints.
Sure. And for CLL, to Kirollos' point, I could have comorbidities. I could have prostate cancer. I could have diabetes. I could have dementia, right? And so there's a lot of complex dynamics at play. There's the driving chronic condition, which may actually be dementia, since it's a chronic illness. But in this instance, you could have this be the driving condition, but there's all these other conditions that need to be coordinated as well, right?
Sure, absolutely. Yeah.
And so do you also then, in these medically integrated dispensing services, provide these other meds, or do you coordinate with local pharmacies, or what does that look like when there's this comorbid situation?
So we do our best. You know, when we need to branch out or stay internal, we do our best to coordinate that patient care. But then again, you know, we're limited. Our hands are tied when we lose control of that prescription. That's the biggest thing. And especially as Mike was saying, the number of doublet therapies or combination therapies, ASH 2018, you look at the number of combination therapies that are being looked at in CLL, ibrutinib plus, et cetera, venetoclax plus, et cetera, all these oral oncolytics. We need to be able to provide everything for that patient all at once to really optimize that therapy, especially with some of these medications such as venetoclax. You know, significant risk for developing tumor lysis syndrome. You know, so if these patients are not receiving their allopurinol, for example, as tumor lysis prophylaxis, or other medications, and we're not able to get these to them in a timely manner, or whether the patient needs to be admitted for their titration, everything just, you know, that gap in care just really needs to be addressed.
So it's patient specific, and you have a specific care plan with specific procurement, specific follow-up, particularly in older patients.
Well, I was just going to add, there's one other element. There's probably multiple elements to keep talking about this medically integrated dispensing service and what it means to us and how we know it provides better value to all the stakeholders in the oral space. There's one tool that I know that our organizations or our clinics
and your organization?
Is NCODA, the National Community Oncology Dispensing Association. We have quality standards, and part of those quality standards is taking a look at cost avoidance. And there's one thing that these two practices do very well, and it has everything to do with that coordination of care. So whether these practices are dispensing that oral therapy themselves within the four walls of their practice, or whether or not they have the visibility to track the oral prescriptions that are filled at the mail order pharmacy, the practices utilize the electronic medical records to ensure that patients aren't getting refills for the sake of being refilled. And there's a couple of obvious things that come to mind when you say that. Well, you're taking costs out of the system. So we track that at our practices, and we track that nationally, the cost avoidance. So the prostate cancer patient that is due for a scan halfway through the month, maybe just refill half of that prescription, not the whole 30-day supply, because they're out 12 months, and you know that they may have a holiday or a switch of therapy.
I mean, it sounds like judicious use and stewardship.
Stewardship, doing the right thing for the right reasons. So as we were saying, working with the electronic medical records to ensure that the patients don't have refills for the sake of just having refills, and that we're managing their oral oncolytic therapies more closely. It's not only a cost avoidance aspect to this, but it's also an adverse event risk management that can occur. There are multiple examples where a mail order pharmacy will, due to time fences, mail a prescription on day 24, day 25, because it'll take 2 or 3, 5 days for that to get from one state to another state. And in those 4 or 5 days, they may have seen the provider, like Christina, and Christina may say, let's hold on that, or let's go from 100 down to 75. And then what occurs is the patient goes home a couple days later, they get that prescription in the mail, and they think that Christina changed her mind and wants her to be on 100 milligram versus a 75. And then additional toxicities and confusion can occur from that. So it's not only a cost avoidance aspect, it's also it's also a health and the appropriate therapies.